We are in Chicago at ACC 16 and we are talking about JAMA. This is a new paper that is online and we're talking about the optimal duration of dual antiplatelet therapy after PCI and stenting. It has been the subject of much debate and it is the topic of new 2016 ACC/AHA guidelines. It's a focused update on duration of dual antiplatelet therapy. So this time in JAMA, it's a look at the development and validation of a prediction rule for benefit and harm of dual antiplatelet therapy beyond 1 year after PCI. And to talk about this, I am with the first author of this paper. This is Dr. Robert Ye, who is an MD and interventional cardiologist and director of the new Center for Outcomes Research in Cardiology at Beth Israel Deaconess Medical Center. Let's start first off by noting the fact that we do have this guideline update and you kind of are part of that, right? The DAPT study played a big role in it.
It sure did. I wasn't formally a part of the new guidelines itself, but certainly the new guidelines do reference the DAPT study as well as the DAPT score, which is the predictive model that we're here
talking about here. So why did you set out to come up with a new prediction rule?
Well, after we did the DAPT study, the results, as you know, showed that extension of dual antiplatelet therapy beyond 12 months for patients who had not first had a bleeding or ischemic event after PCI within those first 12 months, reduced ischemic events like myocardial infarction or stent thrombosis, but did so at the expense of bleeding. And certainly within the DAPT study population, a heterogeneous group, there must have been patients who were more likely to benefit from therapy, as well as those who were most likely to be harmed. And as clinicians, what we really want to do is to be able to identify which ones of those patients are the ones who really would benefit the most from extending therapy.
So what did you learn in this secondary analysis of DAPT?
Well, what we set out to do is use a risk modeling approach to identify who were exactly those patients, and we learned that we could identify, in fact, the group of patients who were expected to benefit the most. And we looked at that subgroup of patients and looked at how, when they were randomized to different treatments, how they did. We found that patients with high DAPT scores of greater than or equal to 2, did derive substantial benefit in terms of reduction of stent thrombosis and myocardial infarction without really an appreciable increase in bleeding. Whereas those patients who had low DAPT scores of less than 2, actually were more likely to be harmed. They had overall greater bleeding, but did not have a significant reduction in myocardial infarction, for example.
Now you looked at something like 2 or 3 dozen variables, correct?
That's right.
But the score doesn't require you to know 2 or 3 dozen variables.
No, it doesn't at all. And so we wanted to consider all of the variables that had previously been described that were associated with adverse events. But really, this is a tool for docs. This is a simplified tool for clinicians. There are on the order of 8 variables that need to be calculated. They include things like age, characteristics about the procedure and the presentation that are actually quite simple in my mind to remember, although maybe not off the bat. Right. So we do present a web calculator, and we're in the process of making a web or a mobile phone application that could be used to use this in the clinics.
But at least it's a simple procedure that you can calculate pretty fast.
It is. I think after a couple times, it can take a doc just a few seconds to calculate this in their office with their patient.
Now, with a variety of different scores already available, why choose this one?
Yeah, well, this is, I think, a unique score in some ways. I'm obviously biased when I say this, but what this score does is it simultaneously stratifies the risk of ischemia and bleeding at the same time. So what typical scores have done is looked at risk factors for ischemia independently, looked at risk factors for bleeding, but when we make this decision to extend or discontinue dual antiplatelet therapy, we really need to balance both. And this is the first score that I'm aware of that's able to stratify both endpoints in actually opposite directions, so identifying just the type of patients who would benefit from therapy, which is those patients at high risk for ischemia, but also low risk for bleeding.
I mean, as opposed to 2 different values which might end up bringing you some confusion, this brings more clarity?
Yeah, I think it does bring more clarity. It certainly can guide, in combination with clinical judgment, of course, can guide treatment decisions, I think, more simply. That was really our goal.
And you did an external validation of this too. This isn't just something you created in the middle of the night.
That's right. Well, over many nights, I'll say. But we did validate it in a separate in a clinical trial called the PROTECT trial, and that was not a randomized trial of 2 different durations of dual antiplatelet therapy. It was a trial of just a post-marketing trial of stents. But what we did find is that high DAPT score patients had a much higher ischemic risk in general than low DAPT score patients, including in the PROTECT, and no significant difference in bleeding, although the numerical differences were such that high DAPT score patients also had a lower numerical risk of bleeding.
Now, it's always, when you're talking about scoring or something new like this, it's relevant to patients with characteristics similar to those enrolled in the DAPT study in this case. So I suppose I better ask you, describe the patients who were enrolled in the DAPT study.
Yeah, very important question. This score really should only be viewed in the context of who the patients were enrolled in the clinical trial. Those were patients who were not on oral anticoagulation, who had not had a prior history of significant bleeding, who could take dual antiplatelet therapy for a whole year after PCI, and within that year did not have either a significant ischemic event, a repeat revascularization, or a significant bleeding event. So it turns out that actually ends up being the majority of patients we see. We tend to remember those patients who have significant bleeding events or on triple therapy where we agonize over that decision in clinic, but actually the routine patient that we see after PCI often is one who has no history of bleeding and can tolerate a year of dual antiplatelet therapy.
Now you note in the paper that although the development of the score was pre-specified, the analysis should be considered exploratory.
That's right.
And yet at the same time, is it ready enough for prime time that you should try it out?
You know, it's a hard question to answer. You know, we've developed it in what is the largest randomized clinical trial of dual antiplatelet therapy ever performed. We have conducted a separate validation in an 8,000 person clinical trial which showed that it did do what we expected it to do. Nevertheless, what we haven't done is taken the tool and shown that when you use the tool versus not use the tool, you actually improve outcomes. And so there's talk that maybe we should consider prospectively validating the tool itself and how it impacts clinical care. You know, my personal standpoint is that, you know, I think that one can look at the results and interpret them for the population of patients similar to those of DAPT. I think the tool is effective at stratifying patients. We have to do some stratification anyway, and This is the first data-derived way to stratify.
And what did the updated focus guidelines say?
Yeah, well, the new guidelines made, I think, two types of new recommendations. One, it shortened the mandatory period of dual antiplatelet therapy after PCI with drug-eluting stents from 12 months to 6 months. And for those patients presenting with MI, it left it at 12 months. But it did give a Class 2B recommendation that one could shorten dual antiplatelet therapy in those who were at high risk for bleeding, and it could prolong dual antiplatelet therapy based on the DAPT score, for example, in those patients at low risk for bleeding. And what this score allows you to do is identify who are those patients who fit within that 2B category recommendation, who you might continue, and those patients who you might feel either that you should stop or actually even truncate therapy.
Well, this is a fascinating paper on a very important topic, so please, it is, as we stand here at ACC 16, it is online at JAMA. For CardioSource World News, I'm Executive Editor Rick McGuire.